Hello, everyone. Welcome to this session. I am Hsien-Li from National Taiwan University Hospital, Taipei, Taiwan. We are today going to discuss a case of complex bifurcation treated with ultrathin DS. And I'm very happy today that Dr. Mathias Brandt from Salzburg, Austria, is going to present a very interesting case for us. And also, we are very happy to have Professor Johan Bennett from Leuven, Belgium, to give discussion, summary, and thoughts on this interesting case. And this is my disclosure slide. Okay, so we all understand that bifurcation is a very relevant issue or topic for today's PCI intervention. We all know that from these med system, there are multiple different techniques for almost infinite combination of configurations for the proximal and distal main branch and side branch. So sometimes I think according to the operator's skill and also the disease condition, the choice of a good technique is very important. But I don't think there is an ideal technique for all these lesion geometry. But in theory, we could have an ideal stent that can accommodate all this different geometry as well as different techniques. And we all have experience with the ultra-thin Stent Strategy platform of Orsiro, which in my opinion is already a very good one. But with improvement on the original delivery system, now we have Orsiro Mission. And according to what I know, the combination will give the system better deliverability, better pushability, and also better crossing ability after the main branch stent deployment. So with that, I'm going to hand over to Mathias for him to start the introduction of his interesting case.
Okay. Dear Professor Karl, thank you very much for your kind introduction. I'm Mathias Brandt from the University Clinic of Salzburg. I'll just proceed. This is my conflict of interest slide. I'm going to show you in a nutshell how you get from this presentation to this outcome using ultra-thin drug-eluting stents. And especially I would like to show what procedural benefits you might have when using these devices in an acute case. About the case, it's a rather young patient with an extensive cardiovascular disease. He had 2 myocardial infarctions in the past, which left him with only 22% LVEF. He was supported with an ICD. And now, unfortunately, he had another myocardial infarction. He presented with this. So you can see the ST segment elevations in the anterior leads and also the warning sign AVR elevation. We received him in cardiogenic shock. He was on inotropic support. We put him on the cath lab table because the cardiac surgeons did not want to step in for their recommendation. It was too unstable. So we had no other choice than going forward. We had radial access. We used 6 French guide, and that was the first presentation we saw on the screen. If you look very carefully, you see that there's already stent material in the proximal and in the mid LAD, but this time, as you can see in the spider view, on top of that, there are further problems down the line with the ostial LAD and the circumflex artery. Now, what is the plan? When you look at the lesion distributions, that is a de novo LAD stenosis on top of the previous stents. He has a proximal in-stent restenosis in the LAD, but on top of this also ostial circumflex stenosis and 2 further problems down the line of the circumflex. What is generally possible with this complex situation? I've sorted out the 3 main options you would have for the acute PCI. You may go for a TAP plus kissing balloon inflation. This is the left little slide. That would mean predilatation and then treating the ostium and the proximal circumflex with a stent, and then go along stenting from the left main stem into the proximal LAD with an overlap into the previous stents. It's a good option because it avoids double layer. It's very quick in this unstable patient, but in the precise setting, if you look at the large degree of plaque in the ostial circumflex, you may risk plaque shifting, and it may be a very insufficient ostial diameter in the circumflex. So I would not recommend this. Second option may be DK crush, very successful in left main bifurcations and recommended by the guidelines as well. That would mean putting the circumflex stent a little deeper into the left main stem, then crushing the struts backwards, and from then on, after kissing balloon inflation, placing the left main to LAD stent. So you would still avoid double layer segments, but it's complicated and takes more time. In this case, the patient was still breathing by himself, but unstable. So that was a little too time consuming from my view. And you may risk, if you have problems with kissing balloon inflation, that you cannot place the stent from the left main to the LAD properly. The third option also in guidelines would be culotte. Culotte means treating left main to LAD first, maintaining blood flow into the LAD at an earlier stage, then opening the struts and putting a stent into a left main to circumflex, and after that kissing balloon inflation. You would have a very nice transition into LAD and circumflex from the left main stem. You would have the LAD repair first, which might be an asset in an unstable patient on IV inotropic support. But you have this issue of double layer in the left main stem. And as you can see, it may be a little prudent to think that you get a single stent down the circumflex in the bifurcation setting. I opted for the culotte stenting, so I started with predilating left main, LAD back to left main. That was with a non-compliant balloon, Konica Radon. That is mid proximal LAD in stent and then left main to LAD. Did the same with circumflex to left main, that's proximal, and left main to LAD, left main to circumflex. This is the result after predilatation. You can see we have maintained blood flow into LAD and circumflex at the same time, which is nice. But if you look rather closely, you can see there's a problem ahead. We have created a dissection in the proximal circumflex artery, and the stenosis in the mid circumflex also looks a little more serious than before. So we had to change our concept. We had to place in the stent mid circumflex beforehand, and then proceeded with the initial concept. There is the problem in the circumflex. Then we went ahead with the initial plan to do culotte stenting. We predilated the bifurcation. We implanted a stent from left main to LAD. This is the stent with live view from stent placement. You can quite nicely see the transition into the previous stent material. The next slide shows you stent inflation. And on the next slide, you can see stent with live again with the result after stenting. You can appreciate there's a little overlap zone from the left main stem into the proximal stent in the LAD. You see the caliber difference between both devices. But after all, so far a successful step. After that, we still had nice perfusion of both arteries, and you can see a nice transition from the left main stem into the proximal LAD. Next step would be opening the struts and rewiring and putting a stent from left main to circumflex. This is shown in the left image. We put in another Biotronik zero emission 3.5 stent from the left main with a little offset to the previous stent to avoid a large double layer segment into the circumflex, and at the distal part overlapping to the previously implanted stent. The right image shows you the result, which is quite sufficient at this stage. You can see we have a nice transition into both main arteries. The carina region is not perfect at this time, therefore the next step would be kissing balloon inflation. After opening, after rewiring, opening the cells, again, we put in two non-compliant balloons, Konica Radon 3.5. We inflated both balloons at 14 atmospheres, which you can see on the right side. And the result after kissing balloon inflation was sufficient. So we went on with POT, the proximal optimization maneuver, which is shown in this image. This is also a stent with live image. You can already see that there is a tapering in the stent as expected. So there is a larger diameter in the left main stem and a little narrowing when transitioning to the previous stenting material. And the next slide shows you the final result. This is the areocaudal. We have a very nice diameter in the left main stem. We have a nice transition from the left main into the proximal circumflex and further down into the mid section of the circumflex artery. And we have also a beautiful carina and a nice transition from the left main into the LAD. We did an OCT follow-up 1 month afterwards, which you can see in the next slide. On the lower part of the image, you can see I did a retraction from the mid-LAD back into the left main stem. It shows you there is a very nice adaptation of the stent into the caliber transition from LAD to left main. If you look very closely, you see there's the double layer segment in the left main stem. And I put the cursor just into that double layer segment to show you the benefit of ultra-thin strut devices. You can see that even in the double layer segment where you would expect a rather bulky setting, there's a very low profile of strut material. It's a very nice re-endothelialization after 1 month. And if you look at the 3D reconstruction on the upper left side, you see that there is a very nice conformability of the stent material from the large left main stem into the proximal LAD, and we have maintained a nicely large ostium into the circumflex artery. The summary. So what have we seen during this acute procedure with an unstable patient? We had a swift crossing, recrossing in the multi-stage intervention. We had no trouble to rewire the stents and opening the passage into the side branches. We had an excellent conformability and wall apposition of the ultra-thin struts. And we maintained a low profile of the strut material even in the double layer segments. Thank you very much.
Dr. Brandt, a very nice case discussion. Thank you very much. Lots of interesting features to discuss. We could discuss this case all day, I think. Young patient, STEMI presentation, cardiogenic shock, difficult complex left main bifurcation, in-stent restenosis. So lots of interesting features. You used the OCT mission in this case. I gather that's based upon experience, and I think you've had lots of experience of using this new OCT. What is the advantage you feel of this new OCT mission over the standard OCT and also over other contemporary DES?
Actually, that's a very good question, Professor Bennett. Thank you very much. I had used the OCT mission for quite some time, and I was very confident with this stent, and I thought it was hard to improve. So I was very amazed to see that there was an update coming out from Biotronik. They made subtle changes to the delivery system. The transition from the hub to the shaft has been reinforced, and they created a new embedding of the stent into the balloon, which reduces the crossing profile a little. And then they also made a new transition from the wire to the proximal balloon. You would not feel these changes in simple interventional cases with a type A lesion, but in complex cases where you need the perfect backup and where you have challenging situations with plugs and rewiring situations, you would certainly feel that this translates into advantages. And in this case, I like using ultra-thin struts for bifurcations because the low profile, the low footprint makes recrossing easier. It's easier to find the perfect cell with the wire when you recross to perform cell opening or kissing balloon. And therefore, I think ultra-thin struts may have a benefit when you know you have multiple steps ahead and when you know that you will have to place multiple devices inside or behind each other.
Yeah, so the acute performance obviously is very important, getting the stent delivered. And then we know from our zero data, which is a large amount of data, that the healing is excellent. We know from the large studies, BioFlow 5, from BioSTEMI, STEMI patients that really there's terrific outcomes with the Orsiro. Professor Kao, are there any specific sublesions that you'd like to use this ultra-thin strutted DES for?
Yeah, first of all, I'd like to echo Mathias' comment on the old or classic version of Orsiro. I think in itself, almost, I think the design and also the performance is almost optimal. I think the improvement on the mission is that its deliverability is even enhanced further. Yeah. So this gives us a freedom of recrossing that dilated first implanted main stem stent strut, and then get the second stent go through that side branch opening much more easily. Regarding the thin strut design itself, I think because of these minimum footprint, I think it's already proven in a lot of clinical scenario, even including STEMI, long diffuse vessels. But I think in this complex bifurcation scenario, the most important thing is that in the proximal segment where we have 2 layers of stent material, but still we are leaving behind very, very minimal footprint to be able to have a consistent, early and quick healing of the endothelium, which I think is very important.
Absolutely. I think in-stent restenosis, of course, is also a case where maybe having a thin strutted or ultra-thin strut stent, it has potential benefits. Moving on, as we have a very short time to discuss this case, the left main bifurcation. Dr. Brandt, would you routinely use Orsiro mission in left main bifurcation? Or when might you not consider it?
Actually, that's a very good question. Considering left main bifurcations, make no mistake, these are very complex interventions, like Professor Kao said correctly, and there are really points of no return. So once you place in a stent and you have to rewire, you have to access the side branch, these are time points where you really rely on stent performance. So in that case, you really need the perfect stent and the perfect stent you trust, you know, that's working, because there is no way back once you've been caging the side branch. Actually, one issue for using Biotronik Orsiro or Biotronik Orsiro mission may be the left main diameter. As you know, the largest diameter is 4.0 and the maximal post-dilatation capacity is 4.5. So that would leave you with a certain distance to the upper range of left main diameters. If you look at OCT or IVUS studies, many people have left main diameters larger than this, and Orsiro would be on the lower range. So there are exceptions where I would not be able to use the Orsiro mission just due to the LAD or the left main size, and therefore it is not feasible to implant in every case with left main disease. There is this issue of radial force. Many people have the conviction that radial force is a direct consequence of strut thickness, but that is not the case in this case. It's not true that the larger the strut diameter, the greater the radial force would be. Therefore, the thin strut Orsiro mission is performing really, really well, considering it's a thin strut stent. But if there is very heavy calcification on the ostium of the left main stem, you would certainly consider if diameter and radial force would be sufficient for this case.
Okay, I think very interesting points there. The size of left main is important. Often we use imaging, and I think bench testing has shown that the Orsiro can go up to about 5.2 maximum. So I think correctly choosing the right stent in the left main is very important. Can I summarize this case? It's a nice left main. Use a procedure or a technique that you're familiar with. Learn a tap, clot, DK crush. So that also in acute cases, you're comfortable to perform them smoothly like you did in this case. Keep it simple strategy, very important, yeah. And know your stent platforms which you have available. So thank you for this good discussion.
Thank you very much.
Okay, so that's great case and great discussion. Let's go to the final wrap-up slide. We all know, and I hope that we have convinced you that Orsiro mission ultra-thin DS platform in this specific case offers us easy maneuverability in a challenging scenario, specific for bifurcation as well as the clinical situation, especially when we are thinking about side branch wire reaccess. And also the platform itself benefit regarding the conformability and minimizing stent material protrusion, even with the double layer segment of the proximal main vessel. And also, I think very importantly, the design is very forgiving in proximal and distal vessel diameter discrepancy with very good overexpansion possibility. But we also have to remember that our serial mission platform and the system is not only for bifurcation, it's actually beneficial for almost every clinical scenario. It is proven to be superior in STEMI scenario over other DES standard platforms. Patient and lesion subsets where deliverability is a key factor are also places or conditions where we should consider this platform. Our serial mission is actually a preferred option for challenging cases with even better deliverability performance than its predecessor, the classic Osiro. So with that, I think we should ask Mathias and Johan back. And I really thank you for a nice case presentation and discussion. Any final words to add?
Oh, thank you for taking part in the discussion. It was a great case.
Thank you very much for being able to present my case. Thank you so much.
Okay, thank you all, and it's wonderful.